be done in 2 hours. But your schedule shows 1 hour. So tie up your knuckles and be ready. We'll have a marathon. It's an important topic and I have to go fast. By conceding this fact, you already know so many things. So there is so many revisits. If you're busy in talking and doing other things, then probably there will be difficulty in understanding. So I don't need to act like a policeman and asking you stop your mobiles, blah blah things. Now I presume you are grown up, you are mature, and you know what to do and what not to do. If still you have something to do, enjoy. None of my headache. Enough for enough. So I'll start with, these are my objectives, and my game plan says, I hope everybody knows what is a funnel. So there is a funnel in front of you. This topic is related a lot to this funnel and the concept of this funnel. We all know this is the place from where things enter and this is the place from things goes further. So I like to close the two ends, and this broad part which is receiving is a greater part. I call it false pelvis. And then this remaining part which is aligned, and that I call it true pelvis. So what is the discrimination point between a true pelvis and a false pelvis? Primarily, when a head of the baby reaches to the junction between true and false pelvis, that's the time when a mother starts experiencing pain. And these pains are called, all the pain in the body are called pain. But the labor pain is only pain which is called pains. So it is the most worst type of, most painful condition if we categorize, if we differentiate between different type of pains. So this is the most difficult pain which human being encounters. And when the head of the baby reaches to this place, that's the time when the pain starts beginning. And the passage, like most of us been through, I presume, people who are sitting in this classroom, majority of you were born normally. Very few of you, your mothers have to undergo C-sections. So all of us have gone through this channel from here to here, and this is one of the blindest passage of someone's life. It was all dark, there was nothing, no visibility, no light, no directions. Only we were pushed just with pressure. And who was making the pressure? Our own mothers. And this passage which we've been through from this place to that place, that's the most dangerous journey which we had ever. Think of any sky high roller coasters and blah blah things. Like you might have, I know you might have experienced some very dangerous. What is the most dangerous ride you ever had in your life? Can anybody like to share with me?
Roller coaster with a loop in it.
No, wait, you name it. They have names. They have
Cobra. The Cobra.
Cobra where?
In the mount.
In the mount. Try Hulk in Universal. Then you will see what is Cobra. Anyways, so this is even more difficult than that Hulk thing. Try Orlando, then you will see what it is. So now, this place, this green thing, we call it pelvic brim. This is the pelvic brim. And that we learn in our renal block. There we were saying ureter was showing some narrow point at this place. So now, from this place, this is the inlet. And that's the outlet. Make sense? Now someone, within this place, someone is holding. Someone is putting hand for us. We learned so many diaphragms. One was in the abdomen. That we learned, that is the abdominothoracic diaphragm. You will be learning two more in head and neck. One in the brain, one in the oral cavity. And this is the one in the pelvis. This thing, these two structures which are going obliquely, they are nothing but the pelvic diaphragm. And what is the job of this pelvic diaphragm? It holds the organs which are present within the cavity of the pelvis. What are the organs who lives in the pelvis? The organs are urinary bladder, rectum and uterus in case of females. So these three are the main vital organs who lives within the cavity of the pelvis. And these organs, like those mothers who gave birth, so many childbirth, even that's not the problem. Problem is, sometime during childbirth, to facilitate the passage, there are some instrumentations, there are some extra help which is being used. Because of that, there might occur some injury to the structures who are making the pelvic floor, the pelvic diaphragm. And because of that, once that happens, these women, they suffer from what? When they are sitting in a straining position, they might notice some monster thing coming out of their urethra or their vagina or their rectum. Men can suffer with these things, something reddish, huge, popping out. And that's what? That's called the prolapse. Prolapse of the uterus, prolapse of the bladder and prolapse of the rectum. And it happens. Trust me, once you see that, you will be scared. What is this? Nobody can think of. And this happens just because of our mothers, they suffer. Some of them, they suffer because they gave birth to us. So it happens. And this structure, what I am emphasizing here, this is the one which makes the pelvic floor or pelvic diaphragm. And if this structure becomes weak, we may encounter this sort of problems. So we call it pelvic diaphragm. Now, anything above these two folds, we call it pelvic cavity proper. And in this pelvic cavity proper, we have the pelvic organs. And the area which is below to these, that is the area which we call it as the perineum. Now what is the place? Who lives in the perineum are external genitalia. No matter you are a male or you are a female, your external genitalia are present within this red boundary below and these oblique lines. So this space is the perineum and where your external genitalia lives. And the main organs of reproduction, organs of genitourinary things, they all are living in this pelvic cavity proper. I hope I'm clear. So now we further divide it into, and we have urogenital diaphragm. These are things somebody has to discuss when somebody will be talking about repro. Now, in the sides, in the cavity of the perineum, you can see there are two structures which have emerged on the side walls, and these are inside. They are again a muscle, and this muscle is known as obturator internus. It is inside. You learn a little bit if you go back 100 years back in MSK. There we were learning external and internal obturator, and this is the internal one. So obturator internus muscle is this. Is this clear? Going further, as I said to you, tubes passes out. So I am showing you only one tube, and that tube is rectum. What are the other two tubes? In case of female, urethra and vagina. In males, only urethra. Clear? So now this space, it is helpful. It is helpful when there is an extra expansion. You have constipation. You are pushing. You have big quantity to be excreted out. So this tube can expand. There is a little bit room. Vagina, baby is passing. This vagina can expand, can accommodate this descending baby. So this space is filled by some packing. Like you purchase your some smart gadget. Let's say you have pre-ordered your XS and it is coming. It must be coming in a packing. So it should not be moving and jumping in the box. So this space is called as ischiorectal or ischioanal fossa, and in all of us it is filled with the fat. So this yellow color is denoting to the fat, and this is ischiorectal, ischioanal fossa. Now every living area requires blood supply. So what do I have here? I have the common ileum which enters into the cavity of the pelvis with the name of internal iliac artery. So internal iliac artery is the main artery who supplies the pelvic organs. And external iliac, we learned it last year. And that one, this one, which is going to supply the lower limb. So the major artery of the pelvic region is internal iliac. And internal iliac gives so many branches here. I'm not concerned with the names of that, but you need to be good with the names at least. What are the names are according to the organs. For the uterus, uterine, rectal, vesical. These are the names. Nothing, no rocket science. According to the structures, what it supplies. And remember, we as the doctors of today or tomorrow, what we're going to see, people only come to us once they are in pain. No normal, healthy people will come and visit you, except for your families. When you are on your job, you'll see someone suffering, crying and this and that. No one healthy visiting you. So, and we have to solve their issues. Once it has been solved, they are gone. And again be ready to face another bunch of sick people. Now people, once they are suffering, the worst suffering they have is if somebody develops a cancer. Now when someone is diagnosed, you tell somebody you have a cancer. The first question from the family, from the patient is, how long are you going to survive? What is my remaining life? Will I survive? Will I live for 1 day? Will I live for 1 year? Will I live for 5 years? We are not God. How we tell them? But we have certain learning. We have certain mechanisms. By working on those things, we can predict. Look, if a cancer is confined to an organ, we can say openly, fine, you have still good time to survive. But once cancer has gone to the neighboring organs, to the neighboring lymph nodes, so how we do as a doctor, we just do MRs and CT scan and we look for the status of the lymph nodes. If lymph nodes are disease free, we can predict 5 years. But if they are not, if the disease has gone to the lymph nodes, now we have nothing to do. We have to tell them very clearly, look, whatsoever surgery we do will not resolve it, because you can remove one organ. How many organs you going to remove? It's like wild grass. You keep on picking. You cannot put a zipper on someone's tummy and you keep on taking out the things which have been infected. The cancer goes like wildfire. So, how we know? If we know the status of the lymph nodes. So these lymph nodes, they follow it. They follow the main arteries. And they are named according to that. So the lymph nodes who are present across the internal iliac, we call them internal iliac nodes. Can you see them? Then we have external iliac nodes. And then common iliac nodes. So if the disease has gone to these nodes, now we may think of not the surgery is the first option. We'll start thinking about radiotherapy, chemotherapy, and then surgical intervention. But if the disease has not gone to these lymph nodes, if the disease has not spread to the other organs, there we can plan, we can do some palliative surgeries, and we can give some good relief to the person. Make sense? So information regarding the lymphatics is very, very important. No matter which field of medicine you're going to be practicing, as long as you're dealing with human beings. I'm not talking about if you're working in the labs or just doing some research, that's a different chapter. But if you're dealing with a human being, you have to be good with, according to your areas, the lymphatics. And if you're not good with the lymphatics, every time you'll be crying. So it's the time, restart thinking and just relook into the information. So these lymph nodes are really important. Now, everything is being caved in this pelvis. In this structure, to whom we call it the bony pelvis. So bony pelvis contains all these things. Let's go further. This is, I'm showing you, a male pelvis. A male pelvis is just designed for architectural basis. It's just designed for support, for strength. But female pelvis is different from a male pelvis. And there are major differences and where you need to be good at those informations. Female pelvis is designed for giving birth. Male pelvis are not. So we are not designed. Our pelvises have been tailored not to give birth. So our passages are not that wide. A female should have a wider pelvis. That's why if you look at any female human, you can see that their body is having a different type of chemistry. If you see a male body, it's going in another direction, but female has to have a wider pelvis. And this explains the childbirth. So if you're looking at a male pelvis, everything is narrow. And we are comparing with female pelvis. Ultimately, what is coming up? We are coming up with a narrow ring. Because this ring is not compatible with a human child head. Everyone who's born normally, first thing which goes out is the head. And head circumference is not compatible with the male pelvis. But a female pelvis, now remember this circle. Now I'll go to this. Can you compare the size? Just see that, how narrow, and see things have become wide. Everything is being flattened out. Everything is being expanded. Don't laugh, my dear Yusuf. We all been through this. And we have to, our future. We cannot skip that part. So now, you can see this becomes wide, and this might be one of your questions. The difference between male and female pelvis is very commonly asked. So now you can see the spines are far away, this angle is different, this arch is different, this is shorter, because we have to have this big wide circle. If you compare with the circle before, this is way wider. And why is it important? When a female is being declared that she is pregnant, what is recommended for her? Quickly.
Folic acid.
Folic acid. Fine, thank you. What else? Prenatal exercise. Who will tell her prenatal exercise? She will go to a gym? She will go to a doctor. So that is called antenatal care. So any female who is pregnant, she has to go for antenatal care. And this antenatal care is a place where a person, a doctor who's sitting there, a nurse who's sitting there, they will guide her through the process. Because now this female is responsible for two lives. One is her own life, maternal life, and the child life. So these two lives are important. And now what is happening? The doctor is the one who predicts beforehand, look, lady, your delivery will be a normal delivery or you will be having a cesarean section. She can. How she can? What is the rocket science? Does she have a magic stick? Does she have a magic wand? No. She have to know. You being scientist, look, nobody knows. Tomorrow you will be continuing your career as an obstetrician, as a gynecologist, male or a female. That's not the era. So we need to be good with certain measurements. How we learn, who will teach us. So these measurements are important. And what are these measurements? I don't want to go in detail, but this point number 1 should be good at it. This is a place which I call it pelvic inlet. And this is called conjugate, one of the true conjugate. I want to know this circumference. Because I have to compare, I have to measure the head of the future baby. The head which is inside, that head has to be compatible. If this is bigger than this measurement, do you think it will pass out normally? No. Then you can, ahead of time you have to plan that this patient will go through C-section or this is a normal type of delivery. So this is one conjugate. Point number 2, that was inlet. Point number 2 is the outlet. And there are certain measurements which you need to be good at it. And the story does not end here, only knowing how much is the measurement of inlet and how much is the measurement of outlet. We need to know diagonally how much is the measurement available to us. So this point number 3 is the diagonal conjugates. And the most important, this purple line. And that is known as the obstetrical conjugate. This is the most important. How you do it? What is the science? That is called pelvimetry. Doctor has to insert her fingers into the vagina. She gets these measurements. There are certain reference points. You will be trained for these things, not today, but next year when you will be doing, not next year when you are 4th year, you will be going through the hospital trainings. There you will be seen, you will be told, you are not allowed to do that, but you will be explained how this is being done. And with the time, if you pursue career as an obstetrician, as a gynecologist, you need to be good at these information. So this 1 to 4, and out of this 4, number 4 is the most important factor. If this factor is not compatible with the circumference of the baby's head, this child cannot born from vagina. Then you have to plan for a cesarean section. I hope I'm clear. So out of this whole activity, we need to be good with these conjugates. So the dimensions. Now, there are different type of pelvises. I have put the whole detail here. How it look like? There are different types, different shapes. Once you see this patient in antenatal care, you can predict from there, this is the most normal position. Think others. What you'll recommend, you can tell her right from the beginning, lady, plan a good hospital. Look for what matches you. How much is your budget allows you. So plan with a person who will do surgery. Because this child, if you encounter these variations in the appearance of the pelvis, you can predict ahead of time. Detail has already been shown to you. So these are possibilities. There is a symmetrical and then asymmetrical, and there are so many versions here. I'm not going in details at all. I hope it's clear. Now we need to know about the pelvic walls, how they are made up of, who makes the pelvic floor, how the pelvic diaphragm is being made. So for that, we need to understand some bony landmarks that we did with the lower limb part. You are good with these bony landmarks, am I right? Anything which bothers you? Now, can you see this big opening? What we call it? Obturator foramina. But now we need to close it. This obturator foramina has to be closed. Who is closing it? A membrane. We call it obturator membrane, but we are leaving a gap here. Why we need a gap? For the passage of neurovascular bundle. When I use the term neurovascular, means nerves and arteries and veins. So they pass through this opening. And now this is being closed. And this closed membrane, it is being covered by a muscle here. And that muscle, we just talked shortly about that. And that muscle was obturator internus. We'll come to that. So are you good with this picture? Anything which bothers you here? Anybody who's not clear about any structure, please feel free to ask. Are you clear with this? Now, this is how I'm standing in front of you. My anterior superior iliac spine and my pubic tubercle are in one plane. Anybody who's standing, this is how the position of the pelvis is. Now, I have a ligament which extends from the sacrum to the pubis. So to the iliac part of this thing. So I call it anterior sacroiliac ligament. When I use the word anterior, it means there must be someone posterior. Now going further, another ligament from the sacrum to the tuberosity. So just the name. Sacrotuberous. Very good. And now another one. From the sacrum to the spine. Sacrospinous. Mashallah, you guys are good. So now by having this sacrotuberous and sacrospinous, my greater sciatic notch and my lesser sciatic notch, they convert it into foramen. Make sense? So this point number 1 is greater sciatic foramina and point 2 is lesser sciatic foramina. Why we have these foramina? For passage of certain structures from within outside or from outside to inside. Something is coming in, something is going out. Clear? So now going further, there is someone. Who's this? Piriformis. Guys, piriformis we learn. But what is so important about piriformis? You remember last year, I was talking about, this is a key muscle. What is important about it? Hypertrophy, thank you. What it causes? Piriformis syndrome. What is that? Compression of the sciatic nerve. How the patient will come to you? Huh? Not sciatica.
Probably an athlete.
Yes. Salah. I still remember you guys, don't worry. Huh?
I remember certainly something would be wrong in the book today.
My dear, it's not that medicine is not be wrong. I need exact point how patient will present to you. Patient, okay. Now let me give you some clue. Patient have a fracture of head of the fibula. How he will present to you? Drop of the foot. Right? Remember? It was one of your auspice station. Now, sciatic nerve. Its outer core is common fibular. Inner core is tibial. This muscle hypertrophied. It causes compression on common fibular nerve. So anything related, as much is the pressure, so you should have this concept very clear. As much is the pressure, that much will be the involvement of the common fibular nerve. Patient may present to you with a foot drop or may present with some sensory loss. So patient will never come and tell you, doctor, I have hypertrophy of my piriformis muscle. He will come to you, I feel numbness, I feel wrist drop, foot drop, I found this and that. Now you being as a physician, you have to retrospectively go back and try to correlate what went wrong. And then you label it, yes, you have piriformis syndrome. How you know it? Because if you know about that, it is very closely related to the sciatic nerve. And sciatic nerve, if you look for its architectural formation, its outer core is common fibular and inner core is tibial nerve. If you have this concept very clear in your minds, then probably you can understand what is happening and what went wrong. So, piriformis, I talk about the obturator membrane, the area where it is, it's covered by obturator internus muscle, and this muscle also leaves a gap. This muscle, every muscle of our body is covered by fascia. And that's been given the name of the fascia of that particular muscle. The same is here, obturator muscle covered by its fascia, we call it obturator fascia. Obturator fascia, it becomes thick at one point. So this thickening, before I am going to the thickening, there is another muscle from the coccyx segment of my vertebral column and going to the spine, we call it coccygeus muscle, and then there is a thickening within the fascia of this obturator internus muscle, and this thickening is given a name. That name is, what's the name? Suggest. Tendinous arc of levator ani. What is that? From where it's coming? This is the place where we have the attachment of levator ani muscle on the obturator internus. So obturator internus muscle is attached to this thickening. Because of this thickening, that deep fascia becomes extra strong to support this levator ani, whose job is to hold the organs of the pelvis. Is that clear? To understand it better, let's remove that part. Lower part of the obturator internus has been chopped. Now, we are back to the same picture. Same tendinous arc is there. Now, this is how levator ani. So, levator ani from right and levator ani from left, they meet in the midline. And their job is to hold the pelvic organs. And through this levator ani, we have the passage of different tubes. Tubes are from rectus to urethra to vagina. So there we can see that there are holes. And now, this levator ani muscle. This is my coccygeus muscle. Can you see that there is a pattern being formed? Some carpet, some sajada. So you have one muscle, other muscle, other muscle. So they are together making a floor. It's not one muscle who makes my pelvic floor, pelvic diaphragm. These are three. The walls, you can see that somebody will be coming from up. Who will be coming? Psoas major. It will be sharing with iliacus. So I have iliopsoas. So this is how I am making the walls of the pelvis and the floor of the pelvis. Is that clear?
Doctor, so all muscles apart from levator ani are lateral?
Or?
Lateral.
No, levator ani, coccygeus, piriformis, they are making the base. They are making the floor. In the lateral walls, we have obturator internus, psoas major and iliacus muscle. Are you clear with this image?
Yes.
Guys, this is a very conceptual type of lecture. You have to think 3D. Now era is 8D. I'm saying, still talking very old. Think 9D. Then you can understand. Now, what happens? Does it happen? Your bladder has little amount of urine and it passes without your notice? Kamal. What happened? You get a signal. Only if you are in extreme of ages, you are just born or you are very old, then you don't know. You have some urine, you wet your clothes. So there is someone who controls it. Your rectum is full, but you need to look for a restroom. It's not happening, you pass like a dog. You lift the leg and start business. Does that happen? So you have to locate a place to fulfill your requirement. Make sense? So someone must control this activity. Who's this someone? These are sphincters. And from where we get sphincters? These are muscles. These are modifications in the muscles. So part of my levator ani muscle changes its function, and the one which is going around these tubes, that part becomes specialized, and that will act as sphincters. And sphincters are so many, it's not one. We have so many sphincters, and from where we are getting them? We are getting from the main mother muscle. So now, this is one tube, rectum. Another tube, urethra. I did not put vagina here in between. Can you see that? The muscle fibers who are just going close to these tubes, they are a little bit spatial. And these muscle fibers are becoming external sphincters. For the rectum, they are rectal sphincters. For the urethra, they are urethral sphincters. But they are external. And primarily, they are skeletal muscles. So skeletal muscles, their nerve supplies are coming from spinal nerves. And internal sphincters are usually smooth muscles. And their nerves are coming from sympathetic and parasympathetic. Thank you. Is this clear? So that's the mechanism. This is how it occurs. So, external anal sphincter. So part of the muscle who surrounds the anus, we call it external anal because it's going externally. And then from the urethra, the one who surrounds the urethral opening, we call it external urethral sphincter. Is this clear? From where we get the sphincter, they are nothing special. Same muscle gets modified according to the need, and that brings this help. Now, we are looking from the same thing, pelvis from the top. How it look like? The bony structures. We are good with them, I presume. If you are in doubt, please ask me about anything which I have marked here. Everything is clear? Guys? Now, I am removing those labels. Now I am bringing the muscles. We learned that there was obturator internus. Why I am saying this is obturator internus? Because I can see that there is an opening for the obturator canal. I am making the wall. Then we learned that there was a tendinous arc. From the arc we had the piriformis. No, the levator ani. Now levator ani muscle. Now levator ani muscle is not one. It has three components. Levator ani muscle has three components. Partly is coming from. So let's explore what are the components of the levator ani. The one which comes from the pubis goes to the coccygeus. We give it a name. Pubococcygeus part of levator ani. Make sense? Tell me about that. Nothing. So this is pubococcygeus from the pubis. to the coccyx. Then you can see there is a perineal membrane which covers this gap, right? And now there is another muscle fiber that's part of the levator, and this is from the pubis going to the rectum, surrounding the rectum. So puborectalis. First part is not ligament, it's muscle. It's all about muscles. So first part from the pubis to the coccyx. So we call it pubococcygeus. And then from the pubis surrounds the rectum, goes back, puborectalis. And the third component will be coming from the sides, and that is being given the name of iliococcygeus. Right? From the ilium to the coccyx. So these three are primarily the layers of levator ani. They are different, but together we learn them with the name of levator ani muscle as one muscle. But levator ani muscle has these three components. What are these components? Pubococcygeus, puborectalis, and iliococcygeus. So these are the parts of this levator ani muscle, and you can see them. They are surrounding these openings, and there I have the piriformis, and in between I have the coccyx. Can you see that the floor is complete now with the side walls, and this is the floor. And because this levator ani goes obliquely, so it makes the floor and it contributes to the walls as well. It's completely wrapped, completely a closed sheet from the front to the back. Is this clear?
Doctor, the last muscle that you inserted, the iliococcygeus, is it above or below the pubococcygeus? Or does it just fuse with it?
They are blended together. You cannot separate them out. If you cut through, you cannot say this is puborectalis, this is pubococcygeus, and this is iliococcygeus. They are blended. This is for your understanding. I have drawn them this way. Otherwise, if you give an incision, you will never find any demarcation in between. Only if you do the studies, myotomal studies, then you may elicit this is that part, this is the other part. But surgically, you cannot see them. Even in cadavers, if I take you through the cadaver's back, you cannot show me which one is what, and only you can say these fibers belong to this part because they are surrounding. These fibers are going here, that's why they are given this name. But technically, they are going in a similar direction. I hope it's clear.
What's this up?
This one?
No.
I'm coming to that. So now urethra is being surrounded further. There is a modification. This is compressor urethral muscle. And then in females, urethrovaginal sphincter. So it makes a sphincter there also. This is an opening, my dear. Make sense? Now, everything is covered with a fascia. This is inside, superior. And done. Now I like to make a cut. To see all this, the whole bony pelvis and the pelvic floor muscles and the lateral wall in a coronal or frontal section. How things appear to me. So it's like that. We can see on the side the bones are. The ala of the ilium, this is the acetabular notch, and down this is the pubis. Like you're sitting here, you're sitting on this bone. Now let's fill it. Pelvic brain, iliacus muscle, my iliacs, obturator internus, the fascia who covers it, the tendinous arc, levator ani, make sense? Now we talk about anal canal, the most strongest sphincter provided to human beings is the one which controls the anus. People become incontinent for urine, but getting incontinent for rectum, for the anal canal is very less likely. You have very less commonly seen, less commonly observed, someone passes his stool and he don't understand what is happening. Extremes of ages. or some really sickness like somebody develops severe diarrhea. Now person has no control, totally lost, passes stools, he didn't notice he or she. So why this is happening? Now we start making it. Sphincter, anal sphincter. There are 3 external sphincters, 1 internal sphincter. All the other body sphincters are not this many. That's why it is so strong. The most strongest sphincter of our body. Let me tell you, when some people have the cancer of the bladder, and these people are not in a good health, normally what we do, we remove their urinary bladders and then we reconstruct urinary bladders. We cannot purchase a urinary bladder from Nadi and insert it inside. We have to make pouches. We have to use any part of ileum, part of jejunum, or some other thing. That's a big different rocket science. I'm not discussing it here. But we make a separate pouch. We need to do what? We need to get a reservoir. We need to get, because we connect the ureters to this new made urinary bladder, and then we exteriorize it, we connect it to the urethra, so urine whatsoever is made is passing out. In certain extreme situations, when we see the patient health is not proper, what we do, and we don't have time to make the pouches, to make the artificial urinary bladder, what we do, we take the ureters, we chop it from the cancer urinary bladder, we remove that bladder out, take those 2 ureters, put it into the sigmoid colon. We connect it into the sigmoid colon. Now this person never leaks his urine. Only his urine accumulates within the rectum and he passes this when he is to go for passing his feces. That time urine comes out with the feces. But otherwise there is no such thing. It's not happening. You connect the ureters to the sigmoid colon and now you can see that this person is continuously leaking or wetting his clothes. It's not happening because the strongest sphincter of the body are closing or controlling the anal canal. This is what we do. So this is about. So let's bring those sphincters. So now you can see that 1, 2 and 3. These all are external anal sphincter. And there is my number 4. This is internal anal sphincter. External anal sphincters are controlled by spinal nerves and internal anal sphincter is controlled by autonomics. Clear? There is a fact. Ureters, peritoneum. Now this is something very important. The fascia who covers my obturator internus, in its lower segment, it leaves a gap. There is a gap here. And this gap is to transmit something very important. And this space is converted into a canal type of thing. This is a section, that's why we're seeing it like that. This is called Alcock's canal or pudendal canal. And what passes through the pudendal vessels and nerves. And these pudendals are very important. How and when they are very important? During a childbirth. Normally we don't give anesthesia to the lady who undergoes the labor. So now if you see that, the head of the baby, by all your measurements, sometimes it happens, everything fails. By all things, you are thinking that this baby can pass through, but now the baby head got stuck. It is an emergency. You cannot rush this lady to operating room even. And there are so many prerequisites required. Now, if you allow her to continue pressurizing, continue compressing on, so baby can pass out, there is a chance that vaginal opening, there might be a tear. This tear can go in any direction, can disrupt the anus, she get some problem. So we need to give a controlled tear. What we need to do, we need to cut. We need to make a slit. That is called episiotomy. What we do for that, we need to give a quick anesthesia. We don't make her sleep. We don't want to, because if she is sleeping, who will push the baby out? If she is asleep, she will never push the baby out. Now what we do, we block this pudendal nerve. We give a local anesthetic, an injection into this nerve. The nerve gets blocked and now we can cut. This is a very sensitive area of human body around these openings. So we make an incision, we cut it, the space becomes wide, the baby is being delivered out. After that we sew that place. And then she goes fine in 10 to 15 days. It heals and everything is in control, there is no damage. So this nerve, this pudendal canal, this Alcock's canal is important because pudendal nerve lives here, and that is the one which we can block at these situations. Or you are having some patient who's having some whose heart is almost gone. Now you cannot offer him general anesthesia, and there is some pathology surrounding the anal canal or the vagina. Now you have to operate on this person. How you'll do it? That's a problem. So in this situation, if you give an anesthesia, there is a good chance this person will never wake up, because heart functions are very poor and everything is very poor. Life expectancy is not good. So you can do these nerve blocks. You block this nerve, you perform your surgical option, person is fine, you don't anticipate anything what is happening, you do your work and you get out of it. Right? You will learn these things in detail in your future days. But this is something which has to be clearer with you. It's in relation to this pudendal canal. This is the ischial fossa, I talked about it. Going further, same situation. Are you good with this picture? Except for iliacus. Same thing. This is my occlusive membrane. Occlusive internus muscle. Fascia. Here we go. With the uterus. The female parts. And then we have ovary and then vagina. This is how it goes. Right? Similar levator ani. So, at the time of childbirth, vagina can expand because there is a space. There is one thing very important I have to emphasize here. During criminal abortions, do you know what is criminal abortion? Do you know what is abortion?
Yes.
What's that? Someone gets pregnant and for some reason she wants this pregnancy to be terminated. Maybe for health reasons, maybe for some other, because every country and every law does not allow abortions. So, who are performing abortion without any undercover, they are not within the law situation, okay? So what they do, these people are not trained, these people are not good, their instrumentation is pathetic. So the idea was they have to dilate this cervix part of the uterus. So by mistake, because they are not trained people, they are not doing it in the proper situations. So they may enter. Can you see a gap? When you enter from the vagina, there is a gap on the side. This is the opening of the uterus. And there is a gap here. This is the fornix. They may penetrate their instrument from here to inside the peritoneal cavity. And you introduce an infection into the peritoneal cavity, you are born to develop peritonitis. And surviving after peritonitis is a miracle. Very few people survive. So, simply a criminal abortion can give you simplest gift of death with all the complications. And these people are prone to make mistakes. Instead of entering into the cervix, they may enter into this fornix, they enter into the peritoneal cavity, and this is what the problem area is. And you are in the peritoneal cavity, you cause every bad thing. I hope it's clear. Now, I made this uterine artery. Why it is tortuous here? Any idea? Why uterine artery is tortuous?
So once the uterus expands when it's gravid, so
can you hear him?
You don't break the artery.
This uterus has to expand. An organ which is 2 to 3 into 4 centimeters can become so big. Once we were inside, we all were inside. None of us was born in any. Even if you are born, you think you are a test tube baby, you have to go to the uterus and you have to go through the normal process. No test tube is done in only tube. It's just a word test tube. Otherwise, those who are test tube babies, let's say if somebody is sitting here, that test tube thing only your 24 hours outside the uterus. After that your 9 months has to be completed within the uterus. So, for that sake, what happens that when the uterus becomes gravid, it may reach under the diaphragm. So baby size is big. And then after delivery, it shrinks down in less than a week time, goes back to normal. So these uterine arteries are being tortuous. Like your phones, they have a cable which is expandable. And then if you release it, it goes back. So same is happening with the pattern of this uterine arteries. And you know, it happens very commonly. You might find a case in your repro block, a PBL case, lonely lady, I think it's there. And there is someone during a childbirth, accidentally someone ties up this ureter, and then the whole problem starts. Start pouring urine from her vagina, and then you will read that case. I don't want to explain it. So it can happen. Now, I raised a question. People develop prolapse. And this prolapse, I use the word by doing some errors of instrumentation. Errors can happen from any hand. And if these errors happen, they cause damage to certain parameters. And what are those parameters? I will be showing you in this slide. No, not this one, the next one. These are my organs, you can see from the top. Not this one. I hope we are good with this image. Any problem? The pelvic organs have been shown. And what I was talking, people pass their instrument rather going from this passage. They may puncture from posterior fornix into the peritoneal cavity from the pouch of Douglas. Make sense? That's the abortion part. Again the same. Yes, here. So what they do, when they do instrumentation, during instrumentation, they may interfere with some of the very strong supports. And these supports, one of the factor was pelvic diaphragm. Pelvic diaphragm is not the major source, is not the major support. We have these ligaments, cardinal ligaments, transverse cervical ligaments, which are responsible to carry the uterus, to carry the vagina in its position. And if these ligaments, there is not one, there are so many. If they got injuries, if they sustain some trauma as a result of that, now that support is gone. Now uterus, vagina or uterus is liable to pop out through the vaginal opening. Same happens with the urethra, same happens with the rectum. So it can happen if these ligaments are gone. So this is the one, this is number 2, uterosacral ligament, and this is number 3. These are very important supports for the uterus. And these are the one who keeps the uterus in its position. There are other associated, but these are the prime ones. Right? So they are contributing, they are supplementing to each other to keep the organs within their positions. Is that clear? If you have any question, feel free to ask. Yes?
Doctor, are these ligaments above or below the levator ani and associated?
They are within. They are within. They are, nothing is outside.
No, like
They are within the pelvic floor.
So they
are condensation of the fascias only. They are not ligament in true mean. They are the thickening of the fascias. What fascias I am talking here? You know what the fascias? These fascias. You remember Kemper's and Scarpa? This Kemper's and Scarpa, when it goes down in the perineal region, it changes its name, Colles fascia and other fascias. So these fascias become so thick, they act so strong, and they are maintaining these organs together with the pelvic floor muscles, together with other factors. They all are contributing. They all are supplementing to each other. Is this point clear? So these all work together and they all maintain the position of these pelvic organs within the pelvis. If they sustain some damage, if they sustain some trauma, they are liable to become weak, and once they become weak, now this organ may pop out, may descend down, and you will see somebody presenting to you something is getting out of his rectum, something is getting out of her vagina, something is getting out of her urinary urethra, some unusual thing, some monster. I purposely deleted those pictures. If you want, I will upload it for you. You want it? Fine. No problem. So you need to be good at that these are the supports. I'm not going who's the main and who's not the main, but you should be good at that these are the supports, and these supports are nothing but they are the condensations of the fascia. Like you see the fascia who was covering obturator and internus becomes that strong that it is giving attachment to the levator ani muscle, and levator ani muscle is the main muscle which has even 3 parts to it, and its main attachment is coming just from a fascia. So fascia is not any ordinary thing. Sometimes they are stronger than a bone. Like if you remember, in MSK you are learning about interosseous membrane. That was just a membrane who was connecting your radius and ulna and tibia and fibula. But this membrane was so strong, so it was giving attachment to so many muscles. I hope I'm clear. Now, we'll talk about, this is the last part, I have 2-3 slides here, the vessels. We learn about common ilia. We said external ilia goes down, internal ilia comes inside and gives so many branches. I'm not reading the names of these branches. It is primarily having an anterior division and a posterior division. And from there we get so many branches. And they supply all the pelvic organs. Is that clear? It's just memorization part, so I don't want to read one by one. So anterior division gives this, and then we have branches. So many. Now ureter, you can see that goes so close to these arteries. So it is liable. Now comes what? The nerves. So we talk about piriformis syndrome. Can you see that sciatic, how close to piriformis syndrome? Once this muscle enlarges, this muscle hypertrophies, it causes compression on the piriform, on this nerve. Now there is what I'm making pudendal nerve. I talk about it. Pudendal nerve comes and follows this track and we block it here to achieve when we are cutting, when we are giving epidural. Yes. Now, the main plan of the pelvis. You are looking at the abdominal aorta. It bifurcates at L4, common iliacs, sympathetic chain, giving splanchnic nerves. We have so many plexuses here. They all are interconnected. And then you have parasympathetics, H2, 3 and 4. Everything is connected and we are getting sympathetics and parasympathetics. And this is how all these organs, there are secretions, there are relaxations, there are contractions, and there is everything. How it is being controlled? It is being controlled by this autonomic system of nerves. How they are made? We know about that. The vagus nerve, when it reaches down, comes to the abdomen, up to the 2/3 part of the transverse colon. After that, we don't have vagus. For the lower segment, we get some parasympathetic from this S2, 3 and 4. And we have so many plexuses which are within the cavity of the pelvis and which are within the cavity of the abdomen. And they get supplies. You can see that sympathetics are coming to them and parasympathetics have been connected to them. And we are getting the autonomic supplies, sympathetic and parasympathetics. I hope people are good with the functions of, what are the functions of the sympathetic and parasympathetic. And still you are in doubt, in neuroblock, they'll make you explain and you'll be knowing it in more details. I think I'm done so far. Any question? Anything which bothers you?
The 3 parts of the question is